expensive piece of AV.
Oh, this is our whole. This is weird.
Yeah, this is.
I guess it's a good day to be on Zoom. Maybe. I'm gonna. Do you care where I sit, Pilsen?
Yeah. In fact, if you want to go back a level, just because I don't have a mask on, I don't want to get you sick at all.
Need to go to the corner.
Are you gonna open up the mics, Julie? Or should I? Oh. We have a clock. Are we ready? I don't see a timepiece, but that way.
We are at 10:33.
All right, that sounds like a good time to start.
Is it good now?
All right. Good morning and welcome everybody to today's Grand Rounds. I'm Andy Rosenfeld. I am standing in for Julie Dumas today, who is also here, womaning the computer and the tech aspects. So I'm honored to be here to introduce Dr. Copeland, our speaker for today, and hope everyone out there in the Zoomosphere is doing well. So I'll tell you just a little bit about Dr. Bill Copeland's biography and what he's going to be talking to us about today. So he's a professor of psychiatry here. He's the director of research at the Vermont Center for Children, Youth, and Family. His training was as a clinical psychologist here at the University of Vermont, and then he went to Duke University to complete a postdoctoral fellowship in psychiatric epidemiology. He's the principal investigator of the Great Smoky Mountain Study, which is a longitudinal prospective study with over 1,000 participants from rural Appalachia over 25 years. And I think this is what we're going to hear a lot about today. So I'll let him share the details. And it's amazing and seminal work, not just for science and our understanding of human brain and development, but for policy. And I think the group has done a pretty impressive job of leveraging that aspect of Bill's work and contributions. His research program focuses on understanding developmental epidemiology of emotional behavioral health across the lifespan. It includes understanding the interplay between early adverse experiences and genetic vulnerability with other individual, family, and environmental characteristics. He's had support from National Institute of Mental Health, Drug and Alcohol, Child Health and Human Development, the Brain and Behavior Research Foundation, over 100 peer-reviewed manuscripts and journals you may read, like JAMA and JAMA Psychiatry and American Journal of Psychiatry and Molecular Psychiatry and the Proceedings of the National Academy of Sciences, as well as other places you might read Bill's work in the New York Times, Slate Magazine, Time Magazine, and CNN. And on top of all that, he teaches a tremendous undergraduate course with Dr. McGinnis of Healthy Brains, Healthy Bodies. And he is also part of the exclusive VCCYF running club. And I would say getting to know, like, Bill's an amazing teacher and colleague to have. And he runs in the dark, in the rain, in the cold, up mountains, down mountains. And it's a testament to his perseverance, his well-roundedness, his collegiality. He's a very welcoming runner. He's gotten me into some running events I wouldn't have otherwise known about. And he's also incredibly humble. And I think that he is a quiet but spectacular superstar in our midst. And I think it's a real treasure to have him in our department and a treasure to have him talking to us today about the Great Smoky Mountain Study. So with that, welcome to Dr. Bill Copeland. Thank you for speaking with us.
Yeah, thank you, Andy, for that very generous introduction. Andy is also a member of that exclusive running group as well. And I spend most of my Wednesday evenings running at his heels as he just sprints up the hill, So I've enjoyed that a lot. Well, I appreciate the opportunity to talk a little bit about some of our work today. I'm just want to mention to everyone that I am recovering a little bit from a cold, so that's why I wanted everyone to kind of stay a little bit further back. Obviously, being on Zoom, you guys are good and safe. Like a lot of the work that I've done, this was a project that I came to after it had already began. And so I've been able to kind of build on the efforts of others and hopefully kind of take that forward in a useful way. So first off, my disclosures, I don't have any conflicts of interest. I do receive research support from a number of different sources that you can kind of read about here, but no one's ever offered me a lot of money to distort my research at all, and I'm open to any sort of entreaties along those lines. But I don't have any conflicts, but I do have a confession that I want to make. Okay, so I'm actually often a person that takes a little break from following the news. I'm kind of a low engager when it comes to news, and it's for a lot of reasons that I think a lot of people do that. The news kind of has that strong negativity bias, and it also has a bias towards sensationalism. And sometimes I find if I'm kind of immersing myself in that long period of time, it kind of weighs on my emotional well-being a little bit. So I like to take my breaks. But I did see one story recently that got me really excited. And so I want to talk a little bit about that. So the headline here is expansion to child tax credit contributed to a 46% decline in child poverty since 2020. Did anyone see this as well? 46%, okay? 46%. That's a huge reduction. And so I was really excited about this. So if you haven't been keeping up with this story, this was related to the American Recovery Plan that was passed in 2021, where we expanded the child tax credit so that instead of getting $2,000 for children above the age of 6, you now get $3,000. Instead of getting $2,000 for children below the age of 6, you get $3,600. So this was expanded dramatically, and it was also paid out on a monthly basis. So families could begin to kind of rely upon getting this extra income over time. And as you can see, it made a big difference. Now, to understand this a little bit more, we need to talk about what poverty is and how we define it in the United States. I don't want to kind of get into a long discussion here, but the official way that we measure it, and this has been the same for a long time since Molly Oshamsky, way back when, is based upon family size and pre-tax income. Okay, and it's really nice to have a measure like this, which has stayed similar over time, because that allows you to make comparisons historically, right? But it also is considered to be incomplete in a lot of ways. Right now, I think according to the official measure, if you have a family of 4, the poverty threshold is $26,000. So kind of imagine trying to make your way in Burlington with that kind of funds. That would be extraordinarily challenging, right? But we've now introduced this new supplemental measure, which takes into account a lot of the things that we do to kind of alleviate the burden of poverty through some federal programs, including non-cash benefits such as SNAP, housing subsidies, but also tax credits like the child tax credit. Okay, so those are the 2 measures that we currently use. Here's what happened when we expanded that tax credit. This is the historic data going back to 2009. And you can see the orange line, which is the official poverty rate, which has kind of bopped along from a high above 20% to a low recently at 15%. But the real action comes with this supplemental measure because this takes into account the child tax credit. And you can see this has been falling over the last decade. But what happened in that last year was very dramatic. It dropped from about 10% to 5%. Okay. And what this meant is that we had about 2.9 million fewer children that fell below this poverty threshold. And actually, this was affected a lot of children under the age of 6, because it's still the case that families with the highest levels of poverty are those that have young children below the age of 6 and indeed below the age of 1. So 2.9 million children overall that were moved. It also reduced disparities across a number of different racial and ethnic groups, white, non-Hispanic, African American, and Hispanic as well. Large reductions in terms of the number of children in poverty. And this kind of shows that same sort of graph I showed before, broken down by those different racial and ethnic groups. And you can see some decreases for non-Hispanic, white, and for Asian, but the largest decrease, and really the decrease in the disparities, came for African American and Hispanic families. Okay, so this is huge news and made me very excited, right? So this kind of gave me a little chance to dance. I'm not feeling well today, so I can't dance, so I decided to throw up the gift. But I'm sure a lot of you that have been following along with the news knows that this isn't the end of the story, right? So what happened after 2021 when we saw this dramatic decrease? Well, there was a large and long discussion about whether or not we should extend these child tax credits at that level. And there's a lot of discussion about this as part of the Build Back Better Act, right? And this was kind of going on about a year ago right now. And in the end, these child tax credits that had been increased were not extended. And what we saw is that 3.7 more million children moved into poverty in January 2020. Okay, so basically what we did is this dramatic, historic decrease in child poverty, and then we just pulled that football away like Lucy to Charlie Brown, and the rates kind of went right back up, except the outcomes are much more dire than they were in that case. And so this is, I think, using the official rates, but you can see the dramatic increases from December to January, 1 month for a lot of families. And it was, most significant for African American and Latino families. So huge opportunity and a lot of excitement that I had about this, but it has now come to an end. And there's a couple of reasons why I in particular thought that this was a really important policy and a good thing to do. So this is a graph showing the average monthly expenditures for families that are below the poverty line or just above the poverty line. And what you can see is that the vast majority of their funds, above 80%, is spent on things like transportation, rent, utilities, food, cell service, and such, okay? A very small amount of their income, because there is a very small amount of income, is spent on things like diapers, toys, books, education, childcare, and children's clothing. A lot of the things that we think of is kind of being the kind of investments, in children that could kind of improve their outcomes, long term. Only 1 out of every 5 families that are in poverty have the funds available that they can make any contributions at all to some of these important kind of early investments. Of course, this can affect those children across the lifespan. The other reason that I'm really interested in this is because child poverty is strongly associated with mental health. Not surprising, right? This is just kind of one example of that, showing parent income on the x-axis, percentage meeting a mental health disorder on the y-axis. You can kind of see this kind of strong, it seems like a linear association at some of the income levels, and then it gets much steeper when we're talking at the lowest end of the income scale, and the rates get extraordinarily high. So there has been, we've known this for a long time, this very strong link between income and mental health. And for a lot of us, we have the notion that this goes in one direction, that in the direction of poverty leading to more mental health problems in children. Of course, there's kind of a chicken and egg question, right? So it could be the case, like I suppose, like many of you probably suppose, that poverty is a terrible thing. It limits the parents' resources. It can be associated with other sorts of negative exposures, and that can increase the risk for children to experience mental health problems. But there's also another hypothesis that folks that have mental health problems are not able to function very well, maybe in their employment, they can't get ahead financially, and this can lead to financial problems over time. And so this is, kind of been encapsulated in these 2 different hypotheses: the social causation, which is this more kind of environmental explanation of what's going on, and then the social selection explanation, which is really proposed a lot by genetically oriented theorists, that mental health problems can cause folks to drift down in terms of their SES or fail to rise out of the low SES groups over time. Now, at this point, when we see these kind of dichotomies, we know that it's both, right? We all know that it's both. And it's absolutely the case that mental health problems do affect our ability to do what we want to do at work, to get ahead at work, to get ahead financially, and that those financial problems can cause anxiety, can limit decision making, cause physical health problems, and affect mental health in a myriad number of ways. So we're really kind of talking about a cyclic interplay between these things. And there's been a lot of work on exactly how poverty for children can affect their physical health, mental health, and cognitive development. This is, just kind of one model. And the things to take away from this is just the complexity of the multiple ways that financial disadvantage can lead to impaired physical health, mental health, and cognitive function over time. It can obviously do that through institutional ways, through access to resources, educational, healthcare, through the type of environment that the child's growing up in, one that feels safe, one where they're not exposed to violence, one where there's a sense of trust and cohesion among people. It can absolutely affect it through their parents' behavior and their relationship with their parents' availability to them, their parents' stress level. All these things can kind of cascade down and can affect the child's functioning in terms of the child's level of mental health and behavior problems. So there's multiple pathways from kind of poverty to kind of childhood mental health problems. And early on in doing research in this, I was kind of interested in, what are all the interesting ways, and can we get from this distal factor to the more proximal, pathways and such like that. The more I do this, the more I'm kind of interested in focusing in on something which might be more of a root cause that affects a number of pathways to this problem. Okay. So what I want to be focused on today, and what I'm going to be kind of addressing, is, does giving parents money, does improving their economic circumstances potentially improve child's mental health outcomes? That'd be pretty strong evidence of social causation. If by giving them money, improving their lot, you could also improve mental health problems as well. I think there's some good reasons to expect that this might be a really good thing to do, right? Parents know a lot about their kids. They know what their kids need, and they might be able to use those funds to make good decisions that can address their kids' needs in a very efficient way and can kind of, help them out cognitively, mental health, maybe reduce stress. Maybe they can cut back on some of their work. They have a little bit more time to spend with their child and can kind of monitor them a little bit more. It's also a policy that's consistent with a lot of principles that we think are important. Things like autonomy and personal choice, okay? But there's also some reasons to think that there could be some downsides to giving people money and giving parents money in particular, right? So, So first of all, this might affect for them their incentives when it comes to work. And obviously, you've kind of heard this in probably policy debates. Oh, if we give the parents this money, then they're going to kind of stop working and stop contributing and spend all this time helping their kids and doing whatever, But it definitely does affect work-based incentives, right? The other critique is that the choices that they might make with that money might not be the best choices or the right choices for the child, either intentionally or unintentionally. Okay. So the stories that we hear are, what happens if the parent's dealing with an addiction? Okay. And they get this extra money. Might they be likely to take those funds and to spend it, in a way that could further their addiction and might not help out the child, might actually have, detrimental effects on the child. Okay. So that's one critique. There's the other one, is that they might just use it in ways that, they're trying to help out the child, but maybe they just don't know what's in the child's best interest like we do. Okay. And so they might spend it on the wrong kind of investments for the child. It sounds pretty paternalistic, doesn't it? But you've definitely probably heard these sorts of arguments. And I think there's kind of real questions about, exactly what will drive their decision making, and will those be the most efficient sorts of decisions. So there's reasons to think this might be a helpful thing. There's also reasons to kind of have a little bit of caution here too. So before I go forward with kind of addressing how we were able to answer this, I'm going to take a little diversion and take you all on a trip down to Western North Carolina, where the data for this study comes from. Okay. So this is all from the Great Smoky Mountain study, which Andy mentioned at the beginning. And this is a longitudinal cohort study that's been following 1,400 kids for 25 years. So you're probably looking at me and saying, wow, he looks really young for someone that's been doing a study for 25 years. And that's a great observation. I am really young for someone. And that's because I wasn't involved in this study at the very beginning. In fact, this study began when I was in high school in 1992. following these 1,400 kids, 11 counties in Western North Carolina. And really at the time, it was interested in answering one question, which is, in the community, how many kids have mental illness, have mental health problems, okay? We don't have large surveillance studies in the United States that keep track of the rates of kind of mental health problems in all different kinds of communities. And so this was proposing to kind of go in and to look at how children were doing in this mixed urban-rural community. So you probably know your states. This is North Carolina. The blue counties are the areas that the Smoky sample was recruited from. What's missing here is Tennessee and South Carolina. And then right along the border with Tennessee is the Great Smoky Mountain National Park, from which the study gets its name. And that name is kind of worked out pretty well. This is a very rural part of North Carolina. And it also includes this little red dot here. This is the Qualla boundary, which is the reservation for the Eastern Band of Cherokee Indians. So there's two Cherokee tribes in the United States. There's the one large group out in Oklahoma that was brought there through the Trail of Tears. And then there are the group of Indians that decided to kind of skedaddle, hide out in the mountains of Western North Carolina, and later on kind of actually bought a large parcel of land there and kind of established this community, okay? So what does Western North Carolina look like? It's a little bit like Vermont. It's a very beautiful place. When I was living down in North Carolina, I loved going out there and hiking. And it was a really nice place to spend time. But in terms of the broader context, it's also part of what we think of as Appalachia as well. It's part of this south kind of central part of it, right down here. And if we've been following the news, probably better than I have, you know that there's been a lot going on in Appalachia the last few years. They've been hit extraordinarily hard by increasing levels of suicidality, particularly for folks in middle adulthood. And then they've been hit extraordinarily hard by this opioid epidemic, okay? And this absolutely applies to the participants in our study. We've had over 10 of the participants that have overdosed in the past few years. And so that's kind of part of what's kind of going on here as well. The area is rather kind of pastoral like this. Like I said, very similar to Vermont. Lots of small towns, very geographically distributed. There's some sort of isolation in terms of access to resources, access to services. A lot of people in North Carolina think of Western North Carolina as being Asheville, but our study goes like 3 hours. You can drive 3 hours past Asheville and still be in North Carolina, and that's where our participants are located. And it's also an area that experiences higher levels of child poverty than what we see in the nation overall. So this is kind of a rural, high poverty area, and so kind of a useful place for asking some of the questions that we're going to be talking about here. And these are some of the participants that have shared a lot of their time with us over the course of the last 25 years. You'll notice that maybe looks a little bit more diverse than what you might expect from a rural area. And in part, that's the demographics of North Carolina. And in part, that's the fact that we did oversample children that were part of the Cherokee reservation there. And so there's a large sample of American Indian participants, 350, that were part of the study. Okay. And so I'm about to end the little sales job for the Great Smoky Mountain study, but this has been a great study to be a part of, not just because of the questions it started out intending to answer, but because of all the questions that it was able to then address, because it decided to keep following these children up over time. The way life works with grant funding is that you only get 5 years worth of funding, okay? So great reason to start the study. We want to understand how many kids in rural areas are dealing with mental health problems, but then 4 years later, you have to come up with a new scientific justification for it. And if you have a study like this, which has been going on now close to 30 years, that means 6 or 7 different cycles of coming up with a brand new set of scientific questions to answer. And if you ever go back to NIH and say, maybe we should just continue following them because we've already followed them for 25 years. You'll get laughed out of the room. Okay, that doesn't happen. So it's been a labor of love and bag bomb and duct tape to keep this thing going. But what always astounds me when I kind of think about the study is that most of the interesting questions that we've been able to address were not necessarily questions that were on those grant applications, and not necessarily things that occurred to us ahead of time. But if you follow a group of kids long enough, these questions will come up, and you'll be able to address a whole lot of important things. Okay, and including a natural experiment of cash transfers. I'm going to talk a little bit about that now. So now I'm going to take you to the Qualla boundary area. This is kind of right in the middle of the Smoky area, and it's actually not officially a reservation, although the American Indian participants still call it the res. So they're living on the res, and that's the terminology that they use, even though it's not a federal reservation. It's actually a land trust. So the Cherokee Indians were able to buy this land in 1870, 56,000 acres. And so they kind of own that in trust. And they kind of control most of the kind of services, and municipal services in the area, the schools, law enforcement. They have their own hospital. There's about 16,000 Cherokee that live in this area, and it extends across multiple counties right there. Okay. So an interesting thing happened. The study began in 1992, and then in 1996, in the midst of this small little rural area, a little casino sprouted up. And so we have to kind of go back in time a little bit to 1988, to President Reagan signing the Indian Gaming Regulatory Act, which opened the door for this type of gaming activities by federally recognized tribes across the United States. That happened and signed in 1988. The Cherokee developed an agreement with the state of North Carolina to open this casino. It was opened in 1996, and this began to have an effect on the community, because it turns out gambling is really popular. Okay, so this kind of caught on immediately, even though you have to drive, through all sorts of mountains and country roads and everything to get there. It was kind of very popular, and they were kind of bringing in a large amount of funds, even when it was just a bunch of bingo tables. Now it's like 120,000 square feet, and it's got the big concerts come through there. It's got all sorts of gaming and everything else. But this has kind of fundamentally had a huge effect upon this area. Okay, and so the tribe had to decide what they were going to do with these funds that were coming in, and they basically decided to put them into two different barrels. Okay, one of them was to use this to fund the tribe's budget for a lot of the community resources that I mentioned before. So they put money into healthcare, they put money into schools, to a lot of other things that were going on. But with the other half of the funds that they were bringing in, they decided to share these funds with every member of the tribe. So they decided to kind of pay out a portion of the proceeds and the profits from the casino to every adult member of the tribe every 6 months. Okay, so the first time they did this, it was $4,000 for every adult member of the tribe. Now imagine that you're in a family, and let's say that there's two parents in the family. Well, that's not 4,000, that's 8,000. Okay, and you're getting it now, and then 6 months later, you're getting another 8,000. I actually jumped up to 5,000 very quickly. So then you're talking about, okay, like maybe close to $20,000 in extra income that you're getting over the course of a year. That can make a huge difference for any family, and especially for a lot of these families where poverty was extremely high. This had a huge impact as well. So one day, Jane Costello, who was running the Great Smoky Mountain Study, woke up and said, hey, I wonder if this program of transferring profits from the casino to the tribal members is having an effect on their children. Okay, and she proposed this to the other PI of the study, her husband, Adrian Engold, and he said, that's a ridiculous idea. There's nothing to it. Don't even waste your time looking into it. Okay. And so immediately Jane decided to go and look into it because that's the kind of relationship they have. And she did, and we're going to kind of talk about a little bit about what they found. But this is a really great opportunity because what we kind of have here is something that we would have liked to have done, in kind of a more tightly controlled way. But basically, what the tribe was doing for us by, providing these cash transfers was a natural experiment in cash transfers to these families. And this overcomes a lot of challenges in terms of understanding the effect of income on mental health, because we can look at our correlations, but we're not necessarily sure about the direction of that. And we know household SES is not randomly distributed. There are a lot of characteristics that go along with that. We'd like to randomly assign people to different social strata, but there aren't a lot of studies where we're able to do that. And so here we're taking advantage of basically an experiment that's created through government policy. Make sense? Okay. And that's what this whole natural experiment thing is. So I'm going to talk a little bit about how this would work with the Great Smoky Mountain study. And so a couple things that I want you to pay attention to here. First of all, we got started following these kids in 1993. The casino opened in 1996. So you had a number of years of data collection prior to the casino open, prior to the cash transfer starting, where we could look at how these kids were doing, what their mental health levels were, and could make a comparison then to how they did after this opened up too. Also, the design of the study was to recruit 3 different cohorts of children, ages 9, 11, and 13. And so we have children that are also getting this cash transfer in their families at different ages. Some of them are 12, some of them are 14, some of them are 16. This has important implications that I'm going to kind of draw more attention to down the road. So that's the pre-cash transfer period. And then we have this whole period that we've been following them up after the cash transfers began. And we're going to kind of look across that a little bit. As you can see by now, if you kind of get out to 2020, they were in their late 30s. They're now in their early 40s. And we're still bugging them on a regular basis. Okay. So what kind of information do we collect on the participants? Well, most of it was done early on. It was focused on this mental health epidemiology study. So it was done with the structured diagnostic interview, the child and adolescent psychiatric assessment. This was done with the children themselves about their own functioning. And it was also done with their parents about the child's functioning. So then we could combine the multiple informant information to learn about the child's functioning. And we assessed all of the common and some less common mental health problems, ADHD, conduct disorder, depression, anxiety, and so on and so forth. We also have collected a lot of other information, including biomeasures at each time point. We go in there and collect these, do a finger prick and get these dried blood spots. We collected that at each assessment. That's proven to be immensely valuable, especially having that kind of longitudinally, because then we can look at changes in different biomarkers and stress hormones over time. And we've also linked to other sort of administrative records, geocoded them, and everything you can imagine doing over the course of the 25 years the study's been going on. So, question number 1: does giving parents money improve their child outcomes within childhood? Okay. So, first of all, did this have an effect upon poverty rates? Right. These are the non-Indian participants, of which there's close to 1,000, and you can see that levels of poverty trended down a little bit over this period. That happens as kids grow up, but you can see that what happens with the Cherokee participants is much more dramatic. Okay, well, and it was much more dramatic where things were at to begin with too. So over half of our participants fell below the poverty line, our Cherokee participants, and over time, with the introduction of the per capita payments, these rates fell. And you can see fell dramatically by the year 2000. So as an anti-poverty program, this was very effective. Was that associated with any changes in terms of their mental health functioning? So this took those groups and kind of broke up the Cherokee participants into 3 different groups. Those that were persistently poor, those that were poor before the casino opened and continued to be impoverished afterwards, those that were never poor, and now it's kind of self-explanatory, and then the experts. So these were the folks that before it opened, they were below the poverty line. Afterwards, with this additional income, they're above the poverty line, and it compared these 3 groups to one another. And as you might expect, prior to the casino opening, the persistently poor and the ex-poor looked very similar. They had high rates of symptoms, on average 4.3, 4.2 each, and they were both higher than those that were below the poverty line. Okay. Now, after the casino opened, though, these groups changed. And all of a sudden, this ex-poor group is no longer similar to the persistently poor group. Their levels of symptoms drop so that they're non-significantly different from the group that was never poor. Does that make sense? Kind of a reordering of this group. See the drop in the ex-poor, which is kind of suggesting that this cash transfer, which is affecting income, is also having this kind of cascading effect upon the symptoms as well. Okay, so this is huge. This is a big deal, and Jane went and wrote this up, and it got published in JAMA, and NPR called and said, "Hey, let's have a conversation." And I was a clinical psych intern down in Durham at the time, and I was listening to NPR in the morning, like all good people do, and I hear Jane's voice. I'm like, that seems like a pretty cool study, and it's going on, right here at Duke. And so I then sent her an email. I said, I might like to work on this study. And she said, I don't know about that. But eventually she relented. And so I ended up joining the group as a postdoctoral fellow, transitioning onto the faculty, hung out there for 15 years in the middle of which she retired. And I've kind of taken over the study from there. So it's really kind of building on her early work that I'm going to be able to present some of the work I'm going to talk about in a bit. So that was within childhood. That was the first 4 years kind of after this casino opened. Next question was, once the children transitioned out of the home, what would giving the parents money still be affecting their outcomes in late adolescence? Okay. This is a little bit more complicated than the other question, because as the children were growing up and reaching the age of 18, what was happening for them? Well, they were starting to get the cash transfer as well. Okay. So we had to have a design where we could kind of disentangle the money that they were now receiving from the funds that their parents received when they were younger. And the way that we were able to do that is by kind of leveraging this multiple cohort design, where we had kids whose families received the cash transfer at different ages, and therefore they experienced a different duration of the cash transfer in their parents' home. Okay, the youngest cohort experienced the family cash transfer for 6 years, the middle cohort for 4 years, and the oldest cohort for 2 years. And by comparing those groups, we're able to see if that family cash transfer is still affecting their outcomes. And what we saw is at 19 and 21, we looked at a number of different sort of psychiatric outcomes, any psychiatric disorders, substance disorders, emotional, behavioral disorders. We saw that there were differences by Cherokee, non-Cherokee, okay? But again, that could be due to the family cash transfer. It also could be due to the fact that they're now getting funds as well. But we were able to look at this interaction between the Cherokee status and the cohort, and we saw significant effects for a number of the different outcomes, specifically any psychiatric disorder, any substance disorder, any alcohol disorder, and any cannabis disorder. For those of you that work with young adults or early or late adolescent folks, you know that substance disorders are pretty darn important in that age group. So having a policy that can reduce their risk for those disorders seems like a really useful thing. And it's amazing that we're still seeing this effect of what the money that had been given to their parents a couple of years before. Woohoo, right? Write it up, published in JAMA, blah, blah, blah. Okay, so this is great. So we go about, scraping together our funds to kind of keep following these kids. And now we've kind of moved from late adolescence into adulthood. And I picked up the data and it said, well, do we think that the fact that these parents were given money way back when is still affecting the child's outcomes now that they're adults themselves? Specifically, we're going to be talking about ages 25 and 30. Now, a lot of water under the bridge from when this whole thing started. And I'll be honest, I wasn't optimistic that these effects were going to persist. I'm used to a specific sort of a trajectory of interventions, which is that you apply the intervention and it works really well as long as you're getting the intervention, right? And then at some point you remove the intervention and things start to come back together, and maybe you follow up a year and you're happy if you can still see some difference between the intervention and the non-intervention group. And then you don't want to follow them up any longer because you know that things are probably just going to continue to attenuate, right? But this follow-up is now kind of, over a decade after their families received these cash transfers. So in adulthood, we wanted to look at a similar set of outcomes. We wanted to look at how the kids, now adults, were doing in terms of anxiety, depression, their substance symptoms. We also wanted to look at how they were doing in terms of their other areas of functioning. And these are those results. So this is the mental health batch right here. This is the anxiety, depressive, alcohol symptoms, and cannabis symptoms. And what we can see is that for anxiety, depression, and cannabis, the duration of time that their families receive this cash transfer is continuing to have a significant effect on 3 of the 4 different symptom groups. Now, 10, 15, close to 20 years after they received that. And that is with us accounting for the same mental health symptoms before the casino opened, okay? So I'm accounting for the fact that Jimmy had slightly higher rates of anxiety when he was a kid, and now his anxiety rates are lower, and that seems to be associated with this exposure. We then wanted to look at how they're doing apart from mental health and substance use. So I created a number of scales related to real world outcomes like physical health, financial functioning, risky illegal behavior, and social functioning. And here again, we saw effects on their physical health and financial functioning and risky behavior. These are very broad scales with a number of different indicators, which is why it looks like these are kind of smaller effects, but actually the effects were very strong here as well. So it's helping them to be a little bit less anxious, a little bit less depressed, use a little bit less cannabis potentially, and also to kind of do better in terms of important life areas. So again, I was extraordinarily surprised that we were kind of continuing to see this, but this suggests that it's possible that those funds that their parents received really had a long-term impact on their functioning, okay? That persists to this day. So this is kind of like blow my mind kind of stuff. I like I said, I wasn't expecting this, but the next part of this is kind of like outer space, okay? So if you can't handle it, that's okay. I'm still having trouble with it myself, okay? So does giving parents money improve their grandchildren's outcomes? So here we're going to kind of step away for a minute from the Great Smoky Mountain study. Pretty soon we're going to have data on the kids of our original participants. But to answer this question, we decided to use a different data source, okay? And to do that, we wanted to take advantage of administrative data, which is available that we could kind of look at to kind of study the effect of these transfers. And it turns out that there is education data that you can access very easily. There's birth records that you can access not so easily. You kind of have to do an application to NC Vital Statistics and see if they're okay with that. But we were able to link together the education records with information from the birth records about their parents to determine the age of their mothers and whether their mothers lived in this area and received this cash transfer and at what age. Does that make sense? Okay. And what we were specifically looking at here is their offspring's math and reading scores in 3rd grade. You have kids that are near 3rd grade. You know that I think this happens all over the country. They do the standardized testing, and so we were able to kind of use those scores to see whether the money that was given to their grandparents is maybe kind of affecting their math and reading scores. Here we're talking about 2 decades later. Okay, And we did this for the 3 counties around the casino. So we were able to kind of pull in all of the Cherokee participants or Cherokee individuals living there and non-Cherokee as well, and to kind of do this comparison. And whereas in Smoky, we were kind of limited to folks getting this at age 12, 14, or 16, here we had a much broader range because there was some folks, because we're extending this out to the population, who had started receiving this cash transfer when they were 2, 3, and 4 years old, and maybe experienced it for 12, 14 years instead of just the 4 to 6 years, right? So so this was a project that I did with epidemiologists and psychologists at UC Irvine, Tim Bruckner and Candace Odgers. And so Tim did all the analyses on this. And what he found was that using the non-American Indian families as the control, we saw a 0.25 standard deviation gain associated with longer exposure to the cash transfer for math and 0.28 standard deviation gain for reading scores among the American Indian children. Okay, so a quarter of a standard deviation is not trivial at all. That's a substantial amount. And in looking at the NC data, there is a gap, an achievement gap between Cherokee and non-Cherokee children of about 0.4 of a standard deviation. So this was able to knock out more than 50% of the achievement gap. For those that had experienced this, and that's no small thing. We would have loved to see it kind of attenuated completely. There still was a small gap, but here again, we're talking about based upon the duration of their parents' exposure to money that was given to their grandparents. Okay, so we're in the process of writing this up. It may be submitted right now. I don't know, but we're really excited and amazed that there's a possibility. And one thing that's really, for me in particular, that I like to see about this is now we're using non-GSMS data. So it's not just something weird about this study that's been done by, a couple of expats from the UK and me, and blah, blah, blah. But it's also kind of showing up in these other administrative data sources too. So it kind of lends a little bit more confidence to that. It's always important to kind of point out that there's kind of caveats, to these sorts of findings. I typically throw this up for the correlation does not equal causation, but in this case, because this is a natural experiment, we're not actually talking about a correlational finding like this. So it gives us a little bit more certainty that what we're dealing with is something that's causal. It still is a small study in terms of GSMS, and it still is the case that the only folks that received this treatment were those that were American Indian. So we absolutely want to see other examples of this and other studies that can look at similar sorts of effects as well. And there have been a lot of kind of cash transfer studies that have been done, particularly among low and middle income countries. And this is just a meta-analysis of some of those, which show significant effect overall. This is on internalizing symptoms in children. Obviously, here we're talking about like really short term, like within kind of a year or something. So it's not directly comparable to what we did. But again, kind of lends that much more bit of evidence that maybe this idea of giving parents money, maybe there's something to it. Maybe this is something we should pursue. Some of you might have heard about the Baby's First Year study, which is a large RCT that's going on. Greg Duncan and others have collected a lot of money to do a large clinical trial of this, where they're giving about $300 a month to low-income mothers that are just having kids and following them up over time. They've done this with a very strict RCT design. They're about a year into that study. They just published some results showing effects on infant brain activity, on a measure of brain activity that I don't understand at all. So I'm kind of interested in waiting till they kind of have some of the data that I'm a little bit more acquainted with. But it's good to see that this is kind of being tested in that kind of a context as well. So a few tentative conclusions based upon this. First of all, I mean, I think this is the easy one. Just extraordinarily strong evidence for the social causation hypothesis. There's already other sources of that evidence, but this kind of just is kind of one more source for that. Oh wait, so this is really revolutionary. I think cash transfers might be a good thing. Okay, based upon our evidence, based upon those other studies I was talking about, I think that they're probably, I would say that they're particularly good for parents. I'm not yet as certain about doing this on a universal level, the kind of UBI, universal basic income kind of an approach. I think these studies and others suggest that parents make kind of good decisions with these funds. Whether or not it's kind of a great idea that everybody kind of gets this, I kind of leave to others to kind of look at that. It's an easy policy to implement. Hell, we did it, and we could do it again, and hopefully that will be the case. And I hope that kind of is attractive enough to encourage folks to do it. And I hope evidence like this pushes them to. I already mentioned this about non-parents. And I also believe in it being unconditional. I don't think we should be telling parents what we think they should be doing with their funds for their kids. I kind of think parents are in the best position to make those decisions. And based upon our study, it seems like they made decisions that worked out pretty damn well for their kids and then also for their grandkids. So that's why I have a little bit of confidence in that. So what I'd like to see is a lot more of this kind of a thing. I think there was a lot of discussion about extending this, and it was like one senator in one state that held this whole thing up. I don't want to cast any aspersions, but I can say I'm not a big Joe Manchin fan. It was reported that behind closed doors, he said he was a little bit worried about what parents would be spending this money on, and he was worried about them spending it on, interestingly enough, gambling and among other things as well. So I don't know. Perhaps in the future we can kind of shake things up and can kind of get back to kind of doing our little dance and everything else. Otherwise, I just want to thank the folks that have kind of gone before me and allowed me to kind of stand on their shoulders. Jane, Adrian, Lily Shanahan, longtime collaborator, all the kind of grant funding that's kind of kept us going out there. Obviously, the participants that are still willing to kind of take our phone calls and follow up and do their interviews, their parents that got them involved. And then really magic of this study is our field staff. They're embedded in Western North Carolina. They're part of the community. Wanda Burns will go out, find you, wherever you are, to do these interviews. She is just, indefatigable, So I want to thank them as well. And with that, that's all I've got. So I'm willing to take some questions.
I think this is live. Thank you. That was terrific. The Zoom applause is thundering. I don't even know where that camera is. I guess it's up there. Really clear, really impressive. Also, thank you for including the journey as an academic and of a research project and grant funding cycles, because that's so important, but kind of in the shadow scenes of this. So we'll open up to questions in the room, and I think Julia is going to help us also monitor the Zoom, and I may take Mike, which I've already done, to take advantage of asking the first question, which I'm curious about what might be the effects of the theoretically non-active parts of the intervention, meaning having this follow-up, having the interviews, sort of the potential mental health awareness that comes out of the CAPA interviews and all this checking in. And Wendy, I think you said, who will find Wanda, like
yeah.
Knowing that somebody will find you. And if you have thoughts about that, the sort of unintended consequences maybe of being part of this study.
Yeah, no, that's a great question, because of course, I can kind of answer as kind of like a scientist and as the PI of the Great Smoky Mountain study, which is it doesn't affect our results at all, but also know, having kind of talked to participants and Wanda, just how valuable people have reported these interviews as being and how much they've kind of enjoyed them. Ours is a structured interview, but it's semi-structured. So, so people get a chance to really kind of tell their story, within some certain kind of, boundaries here. And I think we already have evidence that kind of tracking this and having folks think about this can result in changes in terms of people making their lives, how they feel about things, how they see things, the narrative of the whole thing as well. I hope it's been valuable to people, because the more and more we do this, the more I want to make sure that these folks that have given us so much are kind of getting something out of this as well. So I can't quite say from a scientific perspective how much of an effect they're getting out of it, but we've had a lot of kind of anecdotal reports of this being a really beneficial thing. At one time, we did have one exception to that, where we'd been asking about kind of lifetime exposure to negative experiences. They said, you know what? I've talked to Wanda about this already like 3 times. Stop asking me about this kind of stuff. And so you're like, yeah, of course, and so we're like, okay, we won't ask you about the lifetime stuff, anymore, and kind of cut them some slack on this. So they've been helpful to us too.
It looks like Tom Achenbach has a question on Zoom. Tom, can you hear us out there? And try speaking. We'll see if we can hear you.
Yeah, I can hear you. Can you hear me?
You're good. Go ahead.
You can hear me?
We can hear you.
Okay, right. Bill, I think this is absolutely fantastic and extremely convincing. And I think you've put it together, in such an impressive way. Advantage was taken, of a natural experiment, but you've done so much to continue to get relevant data and then to assemble it and compare it with other things and so forth. My question has to do with just the role of SES, not necessarily measured by income. And my late wife and I, in 2007, did a review of studies in 16 societies where they had used, can you hear me?
Yep.
Okay. Where they had used our parent, teacher, and or self-rating forms. And these different studies looked at scores for both problems and competencies in relation to various measures of SES, usually having to do with occupational level and educational level. In some societies like China, where education is so important, they used only education. But in all 16 societies, lower SES was associated with higher problem scores and lower competence scores. And that included societies with very good social safety nets. And at that time, virtually no association between ethnicity and poverty. That was before the influx of immigrants. And I'm talking about Denmark, Sweden, and Norway, where there was a long tradition of good social safety nets, and poverty was not associated with ethnicity because the populations were at that time very homogeneous. And it was also true of poorer societies where there's really no association with ethnicity, such as Jamaica, which is ethnically pretty homogeneous, and China, which is pretty homogeneous. And I think that this does not in any way cast doubt on the finding that cash transfers can be very helpful. But even in societies who are already performing, where they're already providing good social services, access to education, minimizing hunger and so forth, you do find this association between problem level reported by multiple informants and different indices of SES. And I think that's just another variable that's there, and that no way argues against having political policies that involve raising the income levels of poor people. So that's more an observation than any kind of comment on your findings or your presentation of them.
Yeah, thank you for that, Tom. I just to kind of add to that, I kind of shown that kind of figure earlier on that had shown that there was that association, even among kind of mid levels of income too, between kind of mental health problems and income. And then it kind of steepened, as you saw, kind of at the lowest levels. So it could be for some of those countries with, kind of more support, that they're kind of cutting off that end of the distribution. But we kind of still see those differences. Some of them may be related to kind of absolute levels of income, but then some of them also might be related to kind of relative levels of social status. Kind of feeling like maybe you're doing okay and you have all of your needs met, but still feeling a little bit kind of less than your neighbor or the person down the street. Which I think there's some good evidence that subjective social status, is kind of part of this picture as well. So, I agree. I think it's kind of there across, the full kind of income spectrum, and there might be other factors that are involved at other ends of the spectrum too.
Yeah, I think that's very true. But there's also differences related to SES in parental, like educational achievement, that is then related to the child's aspirations and opportunities and abilities for educational achievement. And in, there are examples where the actual family level of occupation education is low, but a very bright child is born into the family and outachieves the family greatly educationally, and then is financially very successful. I met some people in China who were born into quite poor rural families, but did very well in school, and then were able to go to a college, not necessarily the best college initially, but did so well. They were then able to go to either a top graduate school in China or come to the US for graduate school. And, they became very successful financially in many cases. Some of them actually went into things like finance and, became quite rich. Other ones became academics. But there is this other dimension of achievement that is reflected in an adult's own educational status and occupation that may not be entirely correlated with the child. Another aside, the magnitude of the association between problem levels and SES measures like occupation education and also competence levels was pretty similar across societies. It was around 3% of the total variance. It wasn't huge, but it was consistent and it was significant. And of course, I think what you're saying is at the very low end of the spectrum, economically, having very little money just creates whole new rafts of problems that are not necessarily associated with the educational level of the parent or aspirations or anything like that. And then compensating for that by giving people money can overcome the barriers to better adjustment and to moving up. So, I think there are several elements involved, but you've certainly demonstrated the efficacy of cash transfers as one mechanism for raising levels in a population group.
Yeah, I appreciate that, Tom. I was just, while you were saying that, I was also thinking that there are some studies that are looking at the effects upon that extension of the child tax credit that occurred last year, and to see if that would be kind of associated with child functioning and child outcomes. I'm a little bit less certain that we're going to see much there, because I think that some of the components that you want to see for these to be effective is that obviously it has to be at a certain level, that it can kind of make a material difference for the family, and I think that certainly is the case. Two, I think that they have to be kind of consistently provided, and moving it to monthly basis made sense for that. But it also has to be predictable. And, so people need to know that this check's going to kind of keep coming. And then they can kind of make, choices and kind of adapt to that. And I think that component wasn't there with the expansion of the child tax credit. And that's one reason why I think I'm a little bit less hopeful that short-term change is going to result in a lot of outcomes.
Let's take a question from the room, and I'll just also remind us that Bill will be available afterward around 12:15 in the Arnold 6th floor conference room for further discussion and questions, and that has a Zoom component too, I believe. So
yeah, and it has snacks as
and
well.
snacks if you can come in person. So give it to Ella McGinnis.
Thank you. Thank you so much, Bill. That was, it was like incredible results, and really appreciate your narrative of that story. because my glasses fall up here. But I was wondering, this community that you've been able to study, you said that, one barrel is the cash transfers and the other barrel that they wonderfully chose to use is investing in their community healthcare and recreational. And I would, assume that that had a wonderful benefit on some of these kids and adolescents, maybe a little bit later, as it likely took some time for that to be there, but maybe the younger kids might have been able to benefit from that a little bit more for longer as well. And I'm wondering, even maybe with that grandkid cohort, if there's any way, or if you have looked at this, is disentangling the cash transferred from that community resources that they were able to have. And if you think transfers would be, that any outcomes would be attenuated if that community investment wasn't there.
Right.
Outside of that.
It's a great question, Ellen. It's exactly because of this issue that all of our analyses have focused on the duration of time that the kind of child received the cash transfer while they were living at home. So within this kind of most recent, the school outcomes, for example, we were looking at, how many years their parent had kind of experienced this, whether it were, from 18 to 0. So we were able to kind of, so that was our way of kind of trying to, in some ways, kind of account for that difference, because obviously everyone would have equal exposure to those community investments. And honestly, we wondered whether the community investments would attenuate our ability to detect any of these kind of family level effects, because there'd be spillover, that would be kind of occurring. And like good things for the community might kind of affect non-Cherokee and might kind of affect the folks, even if their families didn't receive it for a long time. So we've tried to disentangle that kind of using the multiple cohorts, but I'm glad that they're making these kind of investments in the community as well. And in fact, when I think the original paper was published, there was kind of an accompanying commentary too from one of the tribal members saying, there are these other things that we're doing as well. We're investing in healthcare, we're investing in our schools, and it's not just the cash transfers that we're making as well. I think we tried to isolate the effect of just the cash transfers. I think there's been other beneficial effects of the community investments as well.
Are there any folks who live on what they call a reservation who were for any reason excluded from the cash transfer?
No, we don't have any.
Like 132nd Cherokee blood?
I haven't heard of anything like that, although they have gotten a lot more stringent in terms of people qualifying, as Cherokee members, that, kind of hadn't been beforehand. So you have to be very strict about, proving your kind of genealogy, for it. But there was this issue where a lot of non-Cherokee were really interested in dating and partnering with Cherokee girls, and women, because they, had funds, and that was something that our interviewers would kind of tell us, that was being reported kind of going on, so yeah.
So here's a kind of a thought question. I feel like the Smoky Mountain study is pretty great, but if you were able to go back to when you were in high school and they were starting the study and they asked you, knowing what you know now, how could we make this greater? Are there things that you would have changed about the design of the study or added in or subtracted?
No, I spend so much of my time just kind of in awe of this playground, this little sandbox I have to work with in terms of data in this amazing data resource that, I kind of just see it as being much more than I kind of, should be able to have access to. And I've kind of always kind of pinched myself that I get to ask these questions, like, things that are just important to all of us. Like, how is this early experience potentially going to affect you as an adult? And, someone can kind of come to me and say, I'm interested in loneliness, in childhood. And we can then kind of look at that and see how that affects outcomes in adulthood. So I'm just kind of overwhelmed with what I have access to, that I can't really kind of think of all the cool things I could have done to kind of improve it. I will say that when they collected this to begin with, they did stuff like the dried blood spots. You couldn't do almost anything with these back in like 1992. It was just like the assays, required so much, blood, and so there was very kind of limited, and people would have said, no, you can't get DNA off that. You certainly can't get a genome wide, DNA off of it. And now we can get it off of just kind of one blood spot. We collect 10 at each time, So technology has made the study even better over time.
Right, the genome wasn't even mapped at the time to start.
Exactly.
They're very
Exactly,
forward
yeah.
thinking that they did
Yeah.
that. Oh yeah, got another question in the room. Maybe we'll make this our last one.
That's a good. Thanks, Bill. Just really curious about kind of the use of identity and terminology, and the use of the term American Indian struck me because this is something we grapple with in my world of autism a little bit. That people tend to kind of sometimes find certain terms that they gravitate towards versus not. So I'm curious, like over the time with this study, how folks have approached the identity question and
Yeah.
labels.
It's really good because I always feel like I'm always kind of uncertain myself about these sorts of things, and so in talking to the tribal members and to so we now put our studies through an IRB board that they have to kind of get things approved so that we can kind of go in and work with the participants. Whenever I publish a paper from this, I send it into the IRB board and they review it ahead of time, not to say yes or no, can you publish this, but they're doing it a lot for kind of accuracy and language in some of these issues. And they're the ones that have told us they prefer the term American Indian. And so that's the terminology that we use. And so sometimes I have to say to reviewers, actually, this is what the tribe has requested. And so we're going to go with them, in this case. And that doesn't necessarily mean that they're always going to kind of prefer that, but that's kind of been their kind of preferred, terminology, even with the kind of history of that and inaccuracies that are kind of built into that as well. So that's what I'm kind of sticking with for the time being. But that's but still, even when I kind of say it, it does seem a little bit off, to be honest. Yeah.
Well, thank you again for a fabulous presentation. Another reminder that we'll be heading up to Arnold 6410 to continue the discussion, and the snacks will be stimulating.
The snacks are limited to those that have useful questions and comments, of course. So you have to ask your question and then you get your snack. That's what it works.
It'll be an incentive-based discussion.
Exactly. Yeah. It is contingent.
Okay, thank you very much.
Thank you.
Presentation.